The third and the colorectal part will be covered by Dr. N. Mohan. Yes, please. From Meenakshi Mission, from Madurai.
Good morning, everyone. I thank the organizing committee. What I'm going to do is not give just 2 or 3 papers. I just want to give an overview of what happened in colorectal surgery and certain recommended readings. And I'll take you from colonoscopy to colostomy closure. So Dr. G.V. Rao has given a beautiful talk today on science fiction to clinical practice, and artificial intelligence has come a big way in colonoscopy, which was in experimental few years back has come into clinical practice, where polyp is shown as a box as a computer-aided detection, and also computer-aided diagnosis to characterize the polyp as neoplastic or not. Here you can see on the left side colonoscopy where the endoscopist has missed a polyp which has been picked up by the computer-aided program. But limitations are like in the extreme right, where you see the endoscopist is distracted by the box, which is actually a mucosal protrusion, and the polyp has been mixed. So we have to take this as a pinch of salt and also take into consideration the cost. And many studies have shown that polyps less than 6 mm have been picked up by this computer-aided programs. And also computer-aided diagnosis and characterization of polyp and neoplastic is also coming in a big way, where small polyps are through artificial intelligence are diagnosed as neoplastic and the action is taken. And again, small polyps less than 6 centimeters, 6 mm are picked up using these programs. And lot of computer-aided systems have come into the market, and it has come in a big way in clinical practice in Europe and Asian countries. The other thing which has come in new is tumor localization in laparoscopic colorectal surgery using ICG coated endoclips, where 3 endoclips are placed just distal to the target lesion, and it is viewed during laparoscopy. There is a laparoscopic view, ICG view, and the endoscopic view, in which help the surgeons to complete the surgery. And most of the time we use colonoscopy or sigmoidoscopy during surgery, which may be very cumbersome. And technology proves really promising for surgeons. Extending to it, they have added narrowbanding imaging to chromoendoscopy for evaluation tumor response in neoadjuvant therapy in rectal cancers, where vascular patterns have been described for near complete response, incomplete response, and near complete response, and modified endoscopic evaluation criteria has been used for magnifying NBI. Various endoscopic features like ulcers, wall distension, surface pattern, and vessel pattern has been taken care of, and endoscopic features have been categorized as endoscopic complete response, near complete response, or incomplete response. Adding NBI to chromoendoscopy improved inter-rater agreement between experts and non-expert endoscopists for evaluating tumor response in neoadjuvant therapy. And NBI is a promising modality for universal standardization of diagnosis of clinical complete response. Coming into benign colorectal diseases like diverticulosis, this paper was interesting, where laparoscopic peritoneal lavage versus sigmoidectomy for perforated diverticulitis with purulent peritonitis, a 3-year follow-up study, randomized control study, which shows there was higher short-term morbidity in the lavage group in the form of sepsis and septic related problems, but in 3-year follow-up there was no difference in long-term morbidity. Fewer patients had reoperation in the lavage group and fewer patients had stoma in the lavage group. Coming on to colorectal cancers, there are interesting article which published in New England Journal of Medicine where circulating tumor DNA analysis guiding adjuvant therapy in stage 2 cancer from Australia and New Zealand, and which came to a conclusion that circulating DNA guided approach to treatment of stage 2 cancer reduced adjuvant chemotherapy use without compromising on recurrence-free survival. Coming on to rectal cancers, the last 2 years ago, the Rapido trial had come from Dutch and Swedish group, comparing short-term radiotherapy plus chemotherapy, that is total neoadjuvant therapy versus standard chemoradiotherapy for locally advanced cancer, where the total neoadjuvant group had 5 grays given for 5 days, followed by 4 cycles of capox, operated 8 weeks later, and a standard chemoradiotherapy group has 50 grays for 25 fractions with concurrent capecitabine and operated 8 weeks later. And post-operatively, chemotherapy is given 2 cycles of a capox in total neoadjuvant group and 6 cycles of capox in chemoradiotherapy group, where the conclusion was the short-term radiotherapy and preoperative chemotherapy followed by surgery was efficacious. Acceptable toxicity could be used as an alternate for chemoradiotherapy for locally advanced cancer. This is a study which is, I think, we are in our department, we are using the short course radiotherapy for last 10 years and has given good results. And we also have been proposing that this should be used for locally advanced cancer, rectal cancers also. In this study, what was there was in the total neoadjuvant group, significant number of patients had chemotherapy related problems, which was not very severe, but overall results were as comparable. I recommend these recommended studies. There is a management guidelines for low anterior section syndrome. It's a manual project which has international consensus definition of low anterior syndromes, where one or more symptoms or one or more consequence of these symptoms are categorized as low anterior section syndromes, where symptoms like bowel function, altered stool consistency, and consequences of toilet dependence, social activities, dissatisfaction with bowel, and relationship problems. This is also taken, and it was detailed paper where given pathophysiology of low anterior section syndromes like negative impact of stoma, autonomic denervation, compromised reservoir functions, pelvic irradiation, anal sphincter functions, and afferent sensory loss. And they propose a treatment chart where preoperative counseling is very important, dietary modifications, pelvic floor rehabilitation, transanal irrigations, sacral neuromodulations, and ultimately stoma. And I also suggest this American Society of Colorectal Surgeons clinical practice guideline on ostomy surgery, which has in 2022 updated the recommendation. I have just highlighted the strong recommendation part where potential ostomy site should be marked preoperatively by trained providers. In non-obese patients, routine use of rods at the time of loop ileostomy is not necessary. Loop ileostomy closures can be performed using staple or hand-sewn technique. Ostomy site skin approximation should be performed whenever feasible, and bursting skin closures has advantages as compared to other techniques. And I also believe that minimally invasive Hartmann reversal is safe alternative to open reversal. And finally, what I bring you is the stoma closure, prophylactic mesh placement in stoma closures. And a lot of articles have come, and all the studies have showed that reduced risk of incision hernia at the site of stomach reversal when prophylactic mesh were used, and lack of mesh-related infections justify the routine use of prophylactic mesh during stoma reversal. And there are systematic reviews on what type of mesh to be used. There is no particular difference in what type of mesh, but there is poorer results using biological meshes. Thank you.
Are there any questions or comments from the audience? If there are none, I would like to thank Dr. Mohan for his presentation.
Dr. Mohan, just a query. There is a last paper that you quoted. The stoma is a site of infection where the mesh of any variety, whether it is synthetic or biological, it is showing that biological is poorer. So is there a rate of infection if a prophylactic mesh is put in stoma cases? Is the infection rate is higher or it is not higher?
Actually, what has happened is even biological mesh, initially they were proposed for infective incision hernia repairs also, but it was not effective at all. And polypropylene mesh was very good in infective condition also. And same thing, I think biological mesh in stoma care, stoma site, probably some infection which eats away the mesh, and it's not, recurrence rates are higher.
May I just interject by saying that over 10 years ago, your group presented a
Yes,
paper to
exactly.
this forum where they used meshes regularly, and routinely, and they had good results, but they did not publish it.
That's why I stressed this point here.
But you did not publish it.
I will not publish it.
Maybe you should.
Thank you, everybody. Thanks you.
Thank you.